CAMS is the collaborative assessment and management of suicidality. It is a philosophy, of which I've been describing a bit of, about a way of thinking about suicide risk as a coping strategy, and a way of engaging around that, deconstructing and understanding how it is that this person is suicidal and being empathic of that, and then proposing an alternative model that involves stabilization and then the identification of what we call drivers, which are defined by the patient. So most mental health providers will tell you what's wrong with you, and in CAMS we work a process whereby you tell us what puts your life at risk. And when you tell us what puts your life at risk, then we're going to target and treat that and fix those things the best we can so you don't have to kill yourself, because that's our bias. And so we don't apologize for trying to save your life. And that's why we think this intervention doesn't have to go on forever. In our military research, we see soldiers, in this case, responding in 5 or 6 sessions because they really kind of get that they, these soldiers are very capable and very lethal in the methods they choose. They don't overdose, they don't cut, they shoot themselves in lethal ways and know how. But they're also remarkably good at getting better. But then they don't seek treatment. That's the conundrum, is they don't seek treatment. And what's so interesting to me about watching our CAMS providers is that they're really confident. They have a roadmap. There's an assessment treatment tracking tool that's called the Suicide Status Form that is the roadmap of how CAMS works. And you just see they're confident and they're competent and they believe in the intervention, and that affects the patient. I have a keen interest in placeboology and the nature of placebo effects. And I know that the control providers, or let me put it this way, I know that most providers do not feel confident, and that they feel anxiety and trepidation and are maybe thinking, where can I get a bed, and not really listening to the patient. And so the patients pick up on that. And I think that confidence comes through. It changes actually brain chemistry. There's clear neuroscience research on placebo effects. And it's really powerful. And so in CAMS, we're really working to enhance the alliance, increase patient motivation. The patient is a co-author of their own treatment plan. They tell us what the drivers are, and we target and treat those drivers. And we track the risk until they're no longer suicidal. And that's, in a nutshell, what CAMS does. It's a paradigm shift, and I think that's an overused term, but I think in this case it actually applies. To not see a suicidal patient as an adversary or as a threat. Invariably, a suicidal patient invokes a lot of anxiety and fear in the provider, both in terms of their own competency, the life and death scenario, fear of litigation. Things like that really then drive clinician behavior to practice defensively, and I think in a very controlling kind of model. My view is to take a very different approach to this, and it's to basically acknowledge that people can kill themselves, do all the time. 100 Americans will die by the end of the day. We reckon about 30 to 40% of them will be engaged in mental health care, so clearly patients can do this. So I don't debate that with my patients. I just say, obviously this is something that you are capable of doing, and yet you're here with me. So that sort of creates a interesting paradox, because the law says I can't let you kill yourself, but I don't want to get into that power struggle. And so you have, I think in a conventional sense, a doctor and a sort of a superior provider, or any clinician counselor in a superior position with the law behind them, to work with this person in a coercive kind of way to make them not kill themselves. And I think that's off the mark. I think I recognize that how that dynamic gets created, but the intervention that my group's developed and the philosophy I think is much better is to sort of look at suicidal behavior as problem solving, albeit quite profound, and to propose an alternative way of getting your needs met. But that requires being empathic of that state. And I think a lot of clinicians are just afraid to go there. They don't want to go into that space. It's too frightening, even though they're supposed to by law. And And so that goes to, I think, what you're asking about, which is the nature of the alliance. We know from the treatment research that the alliance drives all our good outcomes. And yet here you have a presentation that pits clinician against their patient or client. And so what we try to do in my intervention and what I think what I'd advocate for is for clinicians to get out of that adversarial position and be empathic. Be empathic of the suicidal state, give up control in a certain kind of way. The nature of paradox is that when I stop trying to control you, I actually have more influence. And so I kind of just lay the cards out on the table. I'll say, I can't make you not kill yourself. I can put you in the hospital for 2 or 3 days, or not very long, and then you could leave the hospital and then kill yourself. I no longer have the fantasy or the delusion that I can actually make you not do this. And if you're here with me, that's important data. That strikes me that you haven't convinced yourself that this is the best thing to do. And I would embrace that and encourage you to engage in treatments that we know work. There's not a lot of them, but I feel like I know one. And you've got everything to gain and really nothing to lose. You can always kill yourself later. But if you're going to try to kill yourself while you're my patient, as a licensed provider, I can't let you do that. So let's be really clear about this. These are the parameters. This is the law. Here's the DC Mental Health Act where I practice. This is what the law says about clear and imminent danger, so, just so you know. And by doing that, I think I'm being fair. I think I'm being reasonable. And what's most important is I think the suicidal person doesn't see me as an adversary. They see me as a supportive ally. And the fact of the matter is they can take it or leave it. I mean, that sounds glib, I know, but it is a free country. And I think we have to embrace a model that basically says, as a provider, this is what's in your best interest. I think you should do this, but it's your life. And I really want you to do this. You've got everything to gain, really nothing to lose. You can always kill yourself later. We all get to be dead for a long time. And that's a pretty powerful pitch. And it is life and death, and I get that. And I've had 6 very close calls with patients, 2 or 3 of which probably should have died, but for extraordinary. So I don't think I'm immune just because I know a lot. But I'm sobered by the fact that I could have a patient next week take their life. But what I have to comfort myself is that I can do what I can do, which is a lot. And that person and their family deserve the best possible care, but it is their life. And I really hope I never lose a patient, but I have to be able to practice what I preach and be able to integrate that, because providers across healthcare disciplines lose patients all the time. But in mental health care, we have these sort of funny double standards. So there's one survey that was published a few years ago, a number of years ago actually, that surveyed survivors who lost a loved one who were engaged in mental health care. And half of that sample saw the loss of their loved one as malpractice. Prima facie evidence, malpractice. That providers failed to save their loved one. And that's just a really interesting piece of data, because you don't typically think of that in other healthcare disciplines, unless there's an egregious a significant departure from the standard of care. So I just find that curious, and maybe they got terrible care. I'm more than willing to say that. I do forensic work. I see how bad the care can be. I'm a pretty harsh critic of my field, I must say, in terms of what I think should change and could be improved. But the idea that half the time it's the clinician's fault, I think is misfounded. And I think part of the problem is that clinicians overpromise, and patients and families have fantasies about the magic of psychotherapy. One of my pet peeves is that mental health is sort of a joke in the popular media, or the punchline, and that movie depictions depict the mental health care provider being crazier than the patient. And but then you need us, and suddenly we're magicians, and we're mind readers, and we have unlimited influence, and we can make people not kill themselves. And I think that's ridiculous. So I'm up for a much more forthright, honest conversation, much like a surgeon would have with an individual. That requires the family to come in and say, these are the risks. You present as a very high-risk individual. I'm not sure this treatment's going to save your life. Folks, one of the implications is that your loved one may kill themselves, and that would be tragic, and I would be within my scope of practice to not work with you. Surgeons do that all the time, and refer you on to another provider. I'm not advocating that, but we don't bat an eye when, we would want that surgeon to do the procedure, if it's even as high risk. But there's a frankness and a forthright about that I think is crucial and valuable for that patient and for the family. But in mental health, we feel like we can't do that. I will oftentimes raise the prospect: you have a patient who's a middle-aged white male who's got insomnia and alcohol problem and is a gun owner and has a history of major depressive disorder and anxiety and agitation, and has a poor history of treatment compliance. And if I'm seeing you in an intake session, I feel like it's within my right as a provider to say, you look like people that kill themselves, and your history doesn't bode well for future treatment. And I actually feel pretty strongly about your wife or your parents or your loved ones to come in to talk about the prospective risk here, because I'm incurring some measure of liability, to be blunt, and it's hard work to work with a case as complex as yours. And for the treatment to work, we know the alliance is necessary, but motivation on the patient's part is really important. And if you're because a judge orders you or because your wife is threatening to leave, I'm not interested in working with you. You've got to want to be here because you want to be here, and not because somebody else is making you, not least of which is me. So that kind of thing is a very frank and maybe seems provocative out of context. But if you put yourself in the mindset of that person, I think it's respectful. I think it's empowering. It's honest, has the great virtue of being honest. And then I think it gets us out of the business of overpromising, and then families being surprised or disappointed. And I have cases of my intervention where there have been suicides. And one case in particular I think about a lot. The family members thanked the provider and said, at least we had the comfort of knowing you didn't have your head in the sand. And they had a very meaningful, and I think continue to have a meaningful contact periodically, because the provider was, of course, devastated, as were the parents. So that may be sort of a sad story, but I think it speaks to a basic truth, which is that we can't save everybody. I don't think I'm immune to losing a patient to suicide. But I think there was a lot more honesty about all this, and it was sort of above board, and we got out of sort of the power dynamic. I think we would save a lot more lives. I think we should aspire to that approach. I guess I feel pragmatic about this, and I feel practical about this, and I think almost for my own self-preservation, my own sanity, that I've got to say over and over again, I can't save every patient, which may sound terrible or pessimistic, but I think it goes to the hubris of, or the fantasy that I can save every patient. What I think I can do is really good clinical work. I think I can do really thoughtful intervention, really thoughtful assessment. I think I've got certain gifts. But suicidal patients in my early career terrified me. They still do. It's very anxiety-provoking to sit down with somebody who's seriously suicidal. And so I'm counterphobic, and gaining mastery helps me manage my anxiety, to be frank. And so I've really taken that to the extreme over 30 years. I need to practice from a sense of confidence and competence versus from a sense of anxiety and defensiveness. And so that's just the truth, that to me, to have something that I know I can do, that I believe the data, that it works, and then we keep on trying to prove. We're really trying to do the big, well-powered randomized trials to really put this over the top as empirically validated treatment. But I have to take comfort in the fact that there are no guarantees in this business. But what I can do is evidence-based, thoughtful, effective, something I know patients like and appreciate, because it's a very different kind of engagement. We've got data that show that the patients like it and they feel taken seriously. They feel like they're not talked down to or stigmatized. Marsha Linehan often says the primary intervention that providers in the United States use is to shame and blame a suicidal person and wag their fingers, shame on you for having these thoughts and feelings. When my take is this person's just doing the best they can with what they got. And that's the tragedy of it, is that it doesn't occur to them that there is often dozens of alternative ways to get your needs met. Because in that suicidal mind, it's kind of boiled down to this. And they're kind of fixated on that. And the beauty of intervention is if you can catch that person and sort of expand that perspective, then there's a lot of things that we can do short of you taking your life. We all get to be dead for a long time. You get everything to gain, nothing to lose. Why don't you give this evidence-based intervention a try? Give me 3 months. So I've loved the work in the task force because it was really one of the first experiences. I've been in the field for 30 years, give or take. And it was one of the first times that things that I felt very strongly about from both a clinical standpoint and from a research standpoint was actually being listened to in terms of the idea of a spectrum of care, stratifying risk, and using some common sense around thinking about working with suicide risk. In other words, hospitalizations are very expensive. I'm not against hospitalizations, but I think there's a subset of people who benefit from that. I think there's, in that regard, too many hospitalizations for people that don't require that level of care. I actually could advocate for longer stays for certain kinds of suicidal people. That said, I think there's a much broader spectrum, as you know, and for this task force to explore the idea that there are different levels of care, different dosages, matching different treatments to different kinds of suicidal states, I think is absolutely at the cutting edge. And the thing I loved about it the most was that it was indexed to sort of political realities and to healthcare reform and to mindfulness that things need to change and that doesn't have to be a bad thing. And so if we're looking at least restrictive treatments, cost-effective treatments, evidence-based treatments, I think it's a new horizon. I think it's a new world, and I really feel very hopeful of the work that we did in the task force and the implications at the policy level, and hope that that can trickle down into what providers do, and then systems. I really felt like the systems emphasis that we took was critical and underappreciated. I do a lot of work going into a hospital or going into a clinic or work at the DoD or VA looking at systems of care to do process improvement projects where we evaluate sort of the current practices and look at procedures and talk to clinicians, talk to patients if we can, to then raise that standard of care.